Hello. Today we're going to be learning about how to take care of the child who has some kind of cardiac dysfunction or deviation. As you're going through this discussion, let me suggest that you have a picture available to you of normal blood flow, or that you have cemented that blood flow into your mind. We're going to be talking about defects, but it's very important that you understand fully how blood flow should go through the heart. If you understand that, as we're talking about the different defects, it will be more easy for you to identify clinical manifestations or assessments that you'll find on your child when there is a defect. But in reality, my pediatric patient can have a congenital heart disease or defect, or acquire a heart disease or dysfunction. The acquired heart disease might be secondary or sequelae to the underlying congenital defect, or it might be something that's not connected to some defect in the structure of the heart. Congenital heart defects are the largest percentage of the birth defects that we see, and there's different causes from the defects, or that can cause the defects rather. You all have learned in OB some viruses that the pregnant mom can be exposed to that can cause these defects. That's one of the reasons we check for rubella titers postpartumly, and we also do that rubella titer initially during the prenatal screen. Rubella is tetragenic to the fetus, and one of the things that we can see is a heart defect. Some other things that can be a result or a sequelae that is connected with a congenital heart defect is congestive heart failure and failure to thrive. As we discussed in a previous slide, the pathophysiology may not be completely known. The factors can include a maternal exposure to something in the environment, some kind of genetic variable that's influencing it. We do know that there's some genetic disorders that there's a higher tendency for congenital heart defect. But irregardless of what the factor is, there has been something that has interfered with the developmental process of the forming of the heart during that stage of fetal development. Heart formation, kidney formation, and the ability to hear all occur around the same time. So a child who has a congenital heart defect, you may also see ordered a renal ultrasound. And not that we don't pay attention to the hearing results in the other children, but we're heightened to make sure that this child passes their newborn hearing screen. You have already discussed the variations in fetal circulation in your OB lecture. I do expect you to be familiar with that. I do expect you to understand that the pressures in the heart of the fetus are greater on the right side than the left. And once a child is born, and you and I, the pressures that exist in the chambers of the heart are greater on the left side, because we have to pump blood out to the body, as opposed to the fetus is not having to do that. I would also expect you to understand that the patent ductus arteriosus, the PDA, is a normal finding in fetal circulation, and also is a patent foramen ovale. Those would be abnormal findings once the baby is born. As the child takes a breath of air, the pressure in the lungs changes, thus the pressure in the pulmonary artery changes, thus the pressure in the right ventricle changes, and the foramen ovale closes as the pressures in the heart change. That's with those first couple of breaths of air. The PDA may not close initially. It can close a little bit later. It can close spontaneously, or we may need to intervene, and we'll talk about that as we talk about some of the defects. So let's discuss the assessment of a child that we suspect with a cardiac dysfunction. We're going to start with our physical exam. Remember, assessment is the first step in the nursing process. All of this goes back to our discussion we've had on doing a physical exam on a child. Think back to what you've learned in health assessment, and we need to apply it. I'm going to be inspecting the child. I'm looking for color. I'm looking for their activity level. As I'm looking at the child, I'm looking to generally see, are they appropriately the right height, the right weight for their age. Obviously, we're going to weigh and measure them and get more definitive numbers, But what does my child look like? Does it look like their body has been able to perfuse their tissue? Does it look like my child has been able to transport oxygen? Does it look like my child's been able to transport those nutrients? I'm also going to palpate. This is where you put your hand over the child's heart. Remember, in my infant, the heart lies more mid-chest. My older child, more to the left and more vertical, like your heart is in position for you. As I palpate the child's chest, I should not feel any thrills. Remember, thrill is the feeling of that extra heart sound. I should hear S1, S2 only. And my younger child with a faster heart rate, picking up on that S3 might be a little bit more difficult, especially as a novice practitioner, but your ears will become more attuned to that. The point being is that a murmur, any clicks, any extra heart sounds, are all abnormal findings even in my pediatric patient. My blood pressure should still be in the same parameters that are normal for the child's age. We do the blood pressure screenings, as you all know, starting at age 3. But if I have a child that I suspect a cardiac defect, I am going to do that blood pressure with every set of vital signs. That's going to be part of their baseline because it's applicable for me to do that. Murmurs can be graded 1 through 5. The higher number, the higher the number, the louder the murmur is. A grade 5 murmur is a murmur that you have the stethoscope in your ears, but you don't even have to put the diaphragm on the child's chest. Remember, a murmur, a good definition for a murmur is turbulent blood flow. And that's what you're hearing. You're hearing this turbulent, you're hearing the blood flow with a greater velocity. It's more turbulent, it's louder sounding, and that's that murmur sound. That murmur sound or that turbulent blood flow could be because the blood is flowing through an abnormal opening. It could also just be, especially in my younger child, that my child is dehydrated and the blood is having to circulate faster. And as it circulates, it becomes more turbulent, and that's what I'm hearing. So oftentimes, especially my younger children, if they're running a high temperature, they've had some kind of gastro issue, they're dehydrated, you listen, you hear a murmur, you hydrate the child up, and the murmur goes away. But if the child does have a congenital heart defect, an abnormal opening someplace, then the blood flowing through that abnormal opening will be a murmur. As we consider some other aspects of the assessment of the child, we're going to review some lab work. We're going to in particular pay attention to the CBC, to notice the hematocrit, the hemoglobin of this child. If the child is having a hard time transporting oxygen, I want to make sure that they're not anemic so that they're at the best or the optimal level of their health to be able to transport the oxygen on the RBC, on the hemoglobin. I'm also going to be monitoring the hematocrit. The hematocrit is the elevation of the hematocrit is something that the body will do to compensate when the body's not transporting or not perfusing the body adequately. Your body thinks, oh, the big toe's not being perfused, let me make some more RBCs to get more oxygen on there, and in doing that, it'll raise the hematocrit level. That's called polycythemia. That's a word that you need to add to your nursing vocabulary. As the WBCs, as the RBCs and the hematocrit increase, then the blood becomes more tenacious. It's harder for it to flow. So now we've got two problems. The child has a congenital heart defect that's not perfusing the body, or not allowing the child to perfuse the body adequately, and I have blood that is too thick to do that. We're going to talk more about that when we talk about some acquired heart disease issues and what the body does to compensate. But for right now, we are monitoring the CBC. You also are going to see some diagnostic tests done for the child. And these are listed right now in order of least invasive to most invasive. As you look through the list, you can see that it requires less invasive procedure into the child's body. Although chest x-ray is listed up on the first, with my young child, sometimes even just the chest x-ray can be very traumatic because I'm having to lay still, or I'm having to lay on a hard, cold piece of X-ray plate. And so from the very beginning, this can be a very traumatizing time for the child and for the parent. And let us not forget that this is something the child was born with. So often there's a lot of maternal guilt or family pointing of what the mother should have done or should not have done. The more invasive the procedure is, the more data that I can collect, though. The chest x-ray is going to tell me if the heart's enlarged, if there's cardiomegaly. And will also tell me if the heart is in the right position. I had one little friend that was 7 years old that she had something called dextrocardia, which just means everything is totally functioning in the heart. Instead of it being on the left side of the chest, it was on the right side of the chest, and had developed pneumonia, and that is why she had the chest x-ray done. And when they found those out, there's nothing we do, there's nothing to do, there's no reason to fix anything. The child's response to the mom was, "Mommy, when I said the Pledge of Allegiance, I knew I should have put my hand on the other side of my chest because that's where my heart was." So the chest x-ray can tell us the shape, the position of the heart. The EKG is going to be monitoring the electrical conduction of the heart, which, remember, we have the mechanical and we have the electrical system of the heart. The echocardiogram will also be able to tell me blood flow, possibly give me some numbers on how much blood is flowing through the heart. Now, I know your book gives you a lot of numbers for ejection fractions and different pressures in the heart. We're not going to memorize those numbers right now. One, because it's really not applicable to you as a novice practitioner. And two, those numbers will change based upon the child's age and size of the child, the body surface area. So if you're taking care of a child post cardiac cath, you're taking care of a child post a repair of one of these defects, yes, you need to know those numbers, because you're going to have invasive lines measuring those numbers, making sure they stay within normal limits for the child. But for our discussion today, just know that there are values in each of the chambers of the heart, plus the vessels, that we would need to know caring for this child. And then the cardiac cath is the most invasive, but gives me the most information. Often a camera can be attached. I can see what the defects are. I can measure the pressures in the different chambers. And as we go throughout this lecture, I can even use the cardiac cath procedure to repair some of the defects. We're going to talk about the nursing process and some nursing diagnoses that apply to a child with congenital heart defects. We have already gone through several slides, and I have yet to discuss with you a specific cardiac defect. That's because we're going to break this content up into 4 different classifications: increased pulmonary blood flow, defects that decrease pulmonary blood flow, defects that are considered obstructive disorders, and defects that are mixed defects. The last category I'm not going to hold you responsible for. I've got some pictures that I'll show you because it's interesting to you as a learner, but not something that I'm going to hold you responsible for the exam. I've broken it up this way because this is how your book breaks it up. You might pick up another resource and it will discuss the defects in regards to 2 classifications, acyanotic and cyanotic. For right now, for your learning, let's keep it to the 4 categories, because this is why. Sometimes an acyanotic heart defect can become cyanotic, and sometimes the cyanotic defect is not cyanotic at first and the child presents an acyanosis. So breaking it up to the way the blood flows is a more reasonable way for you to master this content. And like I said before, this is how your book goes over it. So some nursing diagnoses that can apply to this child is decreased cardiac output, ineffective tissue perfusion, and your most favorite, risk for delayed of growth and development. If I am not perfusing my body, if I am not feeding my body oxygen and nutrients, I am not going to be able to meet all my developmental milestones, not because there's something wrong with my gross motor or because there's something wrong with my fine motor, or I don't want to socialize, or I don't want to develop my language. It's because I do not have the energy to meet those developmental milestones. So the cause is an organic cause for that delay in growth and development. Okay, so let's start talking about some of the categories or classifications of the heart defects. They are based on the hemodynamics of the defects. Hemodynamics is a word that you need to know. Hemodynamics means blood flow. So depending on which way the blood flows will determine what my interventions are, what my nursing diagnosis probably are, what medications I would expect to be ordered, what labs I need to monitor, and what anticipatory guidance and teaching I would do for this parent and this child. So the way the blood flows is the way that we're going to be discussing this. If you are uncertain or do not remember normal blood flow through the heart, that is where you need to start when you're studying. You need to understand all the normal structures of the heart, remember all the names, know how blood flows, what happens, so that when there's a defect or there's a deviation, you can quickly identify if the blood is not flowing through this vessel, what is going to happen in my patient. Let's start with the first classification of a congenital heart defect. And remember, this is based upon the hemodynamics. We're going to be talking about disorders or defects that cause an increase in pulmonary blood flow. Remember that the left side of your heart has higher pressure. So when there's a defect, the blood will flow from a higher pressure to a lower pressure. So you have something called a left to right shunting. Because of the blood flowing from the left side of the heart to the right side of the heart, that then increases the amount of blood that will be pumped to the lungs, thus increased pulmonary blood flow. Because there's more blood flow being pumped to the lungs, a couple of things will happen from a pathophysiology standpoint or from a physical standpoint. Congestive heart failure may develop because I'm not able to adequately pump all the blood to the lungs. Because there's more blood that ends up in my right ventricle to be pumped to the lungs, that musculature becomes hypertrophy. It can hypertrophy to a point where I'm compensating, and yes, I'm pumping more blood to the lungs, but it's not that significant for me. I've compensated and I'm doing pretty well with this defect. It could be based upon the hemodynamics and the amount of blood being pumped or being shifted to the right side of my heart, that right ventricle has to hypertrophy to the point that it's really not even functioning. As those muscle fibers stretch and get bigger, to some degree it helps to compensate, but if they stretch too much and become too enlarged, the size of the chamber becomes too small, meaning the right ventricular chamber, and it's not an adequate pumping of that chamber. What can happen just if I have too much stretching of that blood, or that muscle rather, in the right ventricle, I can actually have either one of two things. I can have the pressure on both sides of the heart equalize so that there's no shunting of blood, or I can have the right ventricle hypertrophy to the degree that the pressures on the right side of the heart actually become greater than the left side. So now I have shunting of blood from right to left. Initially, the left to right shunt took oxygenated blood and now it was repumped to my lungs. With the shunting of the right to left, I now am having the left side of the heart pump deoxygenated blood to the body, out to the body, so the child's clinical presentation is going to be completely different with the shunting of right to left. And we'll talk more about that as we talk about the different defects. So this slide is just to illustrate or to help you understand that it all depends on the blood flow. How that blood is flowing through my heart, the hemodynamics affect my nursing diagnosis. My nursing diagnosis influence my interventions. My interventions include assessment, labs, fluids, medications. things I would expect to be ordered to include teaching and growth and developmental principles. So it all comes down to which way is that blood shunting. Some of the clinical presentations that you're going to see in your child when you do your assessment with increased pulmonary blood flow is the child is going to be tachypnic. Since I am sending more blood flow to the pulmonary vascular bed, I'm increasing the congestion in the capillary bed, so it is harder for my child to exchange gases. Last week we talked about respiratory, and we talked about impaired gas exchange because of constriction or inflammation or mucus or sloughing of cells. It was because of a disease process. Today we're talking about that the child is having to increase their respiratory rate again to help exchange those gases, but the etiology, the pathophysiology, is because I've got too much blood going to the vascular beds in the lungs, and so it is harder for that child to exchange those gases. So the first sign and symptom I'm going to see with increased pulmonary blood flow is they're going to be tachypnic. If breathing faster doesn't help me exchange those gases, then the child's going to increase their heart rate. Because I've increased their respiratory rate, their heart rate, I've increased their basal metabolic rate, and now this child needs more calories. They can have an organic failure to thrive. If this child doesn't receive enough calories, they're not going to be able to have enough energy to do the growth and development, to gain the weight. It is going to take them too much effort just to breathe and beat that heart. In my brand new infant or my young infant, one of the things that's very indicative of a cardiac defect with increased pulmonary blood flow is that this child has a very poor suck. The only work that a newborn baby does is sucking. That's a neurological ability. The brain has to tell the body how to suck and swallow. But if I don't have enough energy to do it, my child will have a very poor suck. So you'll hear the postpartum nurses come in, whether baby's breastfed or bottle feed, and ask mommy, how did the baby suck? Did they have a strong suck? Did you see them suck and swallow? Yes, we're worried about hydration, but in this instance, we're looking to make sure that this child has enough energy to do what they need to do. Okay, so we've gone through several slides talking about some factors that would influence a child to be born with a congenital heart defect. We've talked about the classifications that we're going to be discussing. Right now we're into increased pulmonary blood flow. I'm going to give you a couple examples of defects that cause increased pulmonary blood flow. I will tell you that you really don't need to study these because just based upon the nomenclature, you should be able to figure out which way the blood is flowing. If I tell you that ductus arteriosus is patent, you should be able to figure out that means the blood is going to shunt from the left side of the heart, which is the aorta, to the right side of the heart, which is the pulmonary artery. The blood will then go into the right ventricle, increasing pulmonary blood flow. Sometimes students will be so focused on the defects that they aren't able to understand or comprehend the concepts behind them. And that's where I need for you to be thinking about as you begin your practice as a pediatric nurse. So, a patent ductus arteriosus, as we talked about, that this would be normal in fetal circulation, but once my baby is born, takes a breath of air, keeps the oxygen concentration up, this structure should close. So it's a failure of the ductus to close. There's a connection between the aorta and the pulmonary artery. And this may be necessary. We're going to talk about this defect, that this may be necessary to actually keep open if I have other more severe defects. But for right now, we're just talking about that it stays open. So because there's a failure for the ductus to close, as we discussed before, there's increased blood flow now to the pulmonary vascular beds. Depending on the amount of blood flow, depending on those hemodynamics, right ventricular hypertrophy can occur. We don't see it a lot with this defect, but it doesn't mean that it's not possible. This is just a picture illustrating where the ductus is. You'll see it between the aorta and the pulmonary artery. The signs and symptoms that you're going to see in regards to a PDA is dependent on the hemodynamics. So what that means is the more blood flow, the more pronounced the signs and symptoms will be. You may have a child that it's not symptomatic at all to a child that is very symptomatic. So the size and location are factors that affect the hemodynamics. With any increased pulmonary blood flow defect, the child's more prone to respiratory infections, they can get more tired, you're going to see a poor growth and development, the increased respiratory rate first, the increased heart rate. And when you listen to the child's chest, you may hear wails, and the murmur that you hear is going to be harsh. That's the term we use. It's loud, which makes sense because the defect is not inside the heart. The defect is outside the heart. So it's harsher sounding, and it's continuous throughout the cardiac cycle. When you're reading in the child's chart, when they have a murmur, not only will they grade the murmur, but it'll be in relation to the cardiac cycle, whether it's a diastolic murmur, a systolic murmur, or a continuous murmur. At this point, just know that those terms exist, and this is how we identify it. You will not have, from me or on state boards, an audio portion where you need to identify where in the cardiac cycle it is. The treatments that you'll see ordered for a PDA, again, dependent on the child's presentation, least invasive to most invasive. One of the first things that you may see, let me back up. First of all, a PDA can close spontaneously. So if a child is diagnosed with a PDA, newborn nursery, but they're not symptomatic, they're eating fine, they have a good suck, they don't get diaphoretic, meaning they're working too hard when they're eating. They have a good color to them. We do the echo, they've got good blood flow. We may not do anything other than have the parent follow up with a cardiologist to monitor it, because a PDA, especially a small one, can close spontaneously on its own, so we don't need to intervene. But if we have a child that's starting to have some symptomatology from it, one thing you may see ordered is a medication called indomethacin. Indomethacin is a prostaglandin inhibitor, which causes the PDA to close. Something more invasive, if the child is more symptomatic, they may use coils to include the PDA through a cardiac catheterization. Those coils kind of look like what's inside a ballpoint pen as you click it on and off. They embed the coils where the ductus is open, and then scar tissue forms around it and it closes off. The most invasive, most aggressive type of treatment would be the surgical ligation. Once again, we've gone from a child that's not that symptomatic to the most symptomatic child, where the child is so symptomatic the child doesn't even leave the hospital and has the PDA ligated before their parents even take them home. Another defect under the classification of increased pulmonary blood flow is an atrial septal defect. So if you think about your normal functioning of the heart, there's musculature between the two atrium, between the right and the left atrium. With an atrial septal defect, there's some kind of communication between these two. The type is dependent on the location. Your book does name them depending on where it's at. For right now, we don't need to worry about that. And also with an ASD, this too may close spontaneously. How big the defect is and the location of the defect in the atrium musculature affects the hemodynamics. It's the hemodynamics that influence everything you do for this child. Because the pressure is greater on the left side of the heart, with this defect, I will have a left to right shunting. This left to right shunting can lead to pulmonary hypertension and can lead to dysrhythmias, atrial dysrhythmias. In this picture, you can see where blood is mixing from the left side of the heart to the right side of the heart, thus increasing the blood flow to the right ventricle, increasing blood flow to the pulmonary artery, and increasing blood flow to the pulmonary vasculature. Some signs and symptoms associated with an ASD. This child may be asymptomatic, and the first time that we see symptoms or the child complains of anything is during puberty. The ASD may be small enough where the right ventricle can compensate by enlarging a little bit to get rid of the extra volume in the right ventricle. But it's not enough to impede respiratory effort. It's not enough to impede growth and development. The child does not have frequent respiratory infections, and now the child hits puberty. And because the body, and we go through that growth spurt, and because the body surface area increases, now your teenage boy who's playing sports may say to the parent, you know, Mom, Dad, it's harder for me to run the stadium steps. I'm very tired. Or the teenage girl comes in and she's just especially fatigued. Eventually, the parents bring them in thinking that they have some other disease process, and we listen, and this is the first time we may actually hear a murmur. At that point, we will decide what type of treatment is needed, but especially for my female patient, I want that treated before she starts having children, because any signs and symptoms that she's presenting with will only become more pronounced during pregnancy, because with pregnancy I have increased blood volume. You all know this from your OB theory, and with that increased blood volume I have even more shunting of blood. The hemodynamics, I have more blood flowing through an abnormal opening, and the signs and symptoms become more severe. Just as with my PDA, atrial septal defect may close spontaneously, even with us being aware of it. If it's small enough on my child and it's not causing any problems and they're feeding fine, they're growing fine, there's no failure to thrive, we may just watch it and see if it closes. It can also be occluded during a cardiac catheterization. A more invasive way to treat this is to have a surgical patch put on the opening where it is sewn in place, and the child is kept 1 or 2 nights in ICU and then to the floor, just because the atrial tissue has been manipulated and the child is at risk for dysrhythmias. The next example of increased pulmonary blood flow is a ventricular septal defect. It is the same type of defect we saw in the atrium, but now I'm in the ventricles. Remember, the ventricles, the tissue is thicker, so I have the pressures are greater in that part of the chambers of the heart. So now I'm more likely to have the dysrhythmias. The opening tends to be larger. The murmurs tend to be harsher, and my signs and symptoms are more pronounced as compared to my ASD or my PDA. So I have some kind of communication between the two ventricles. If it's small enough, just as with our other defects, it could close spontaneously. The classification is determined by location. The size may vary, and I have a left to right shunt, at least initially. So the pathophysiology is that the hemodynamics involved is that the blood flows to the defect to the right ventricle. I have an increased amount of blood flow, the blood volume rather being pumped to the lungs. I can have pulmonary hypertension. So all the signs and symptoms we've talked about up until this point, I'm more likely to have in my VSD based upon the hemodynamics. I have more blood going to the right ventricle, so I am more likely to have more of the complications more pronounced. Any of the increased pulmonary blood flow defects can result in a right to left shunt, but I'm more likely to see it in this defect because I have a greater amount of blood flow. My hemodynamics indicate that I'm going to have more blood going through that ventricular defect, that the pressures may equalize in the two ventricles where I have no shunting of blood, or it could be that my right ventricle hypertrophies to the point that I actually change the pressures in the heart, and the right ventricle pressures are greater than the left, and so the extra blood flow is now coming from the right side of the heart. That syndrome or that phenomenon is called Eisminger syndrome, just for you to know the name of it. Here's a nice diagram of a VSD, and you can see where the opening is very pronounced in this picture. So what are the clinical manifestations I'm going to see in this child? Congestive heart failure is very common because there's usually more blood flowing into that right ventricle. The murmur is going to be harsh. This is a child that is at risk for bacterial endocarditis. We're going to talk about bacterial endocarditis under our acquired congenital heart dysfunction, but bacterial endocarditis can happen to anyone. Anyone can get this based upon whatever bacteria invades the heart. But these children are more at risk because the blood flow with a VSD is much more turbulent, and as the blood is flowing, the velocity of the blood is flowing through that opening because of the pressures in the heart, and it's bouncing off the walls of the right ventricle or the valves of the pulmonary artery. It is causing little clots. The little clots clump together, and now I have a protein source for bacteria to grow. So these children are more at risk for it. I'm going to get more tired. I'm going to have shortness of breath. So all the things that we've talked about are more pronounced in this defect. So what is the nurse going to see done for this child? Again, this is a small VSD. My child's not symptomatic, or they're handling everything very well. Least invasive, I'm going to let it try and close by itself. It can also be closed by a cardiac catheterization. Surgically, this is the first time we've talked about palliative surgery for this child. This is a pretty involved surgery. You can see where the PDA wasn't too involved. It's not even an open heart procedure. And then now I'm into a more invasive surgery. So palliatively, if the issue is that I'm getting too much blood flow to the lungs, to the pulmonary artery, we can do something called a pulmonary artery banding, where we restrict the amount of blood flow going to the lungs. We do this to buy the child some time to get big enough to withstand the surgical procedure, to survive the surgical procedure. The complete repair is the use of the sutures and applying the patch. We're going to go to our second classification of congenital heart defects, and this classification is disorders with decreased pulmonary blood flow. So something is keeping the blood from getting to the lungs. There's some kind of obstruction of blood flow to the lungs. Because of that, pressures in the right side increase. You will see a right to left shunt, and what's occurring is a deoxygenated blood is being pumped to the tissues. So already you should be cluing in to what your child is going to look like. That clinical picture when you walk into the room, a child with increased pulmonary blood flow is going to look different than a child with decreased pulmonary blood flow. What I'm going to see clinically for a child with decreased pulmonary blood flow is they're going to have mild to severe desaturation when I put the pulse oximetry on them. It is very important to understand or to obtain that child's baseline so that I can determine if my nursing interventions is helping the child get better or the child is worse. The PaO2 can be anywhere between 50 and 90%. I'm going to have an increase in erythropoietin, and this is where I'm going to see the polycythemia that we talked about before. One defect that falls underneath this category is tetralogy of Fallot. Tetralogy meaning there's four defects connected to this one congenital heart defect. It has a VSD, we've talked about that. Pulmonic stenosis, the aorta is overriding, meaning it's more midline than coming off the left ventricle, and I have right ventricular hypertrophy. When viewing this slide, the right ventricular hypertrophy should be noticed by you. You can see where the musculature really has increased in size. The aorta is more midline, so it's obtaining both oxygenated and deoxygenated blood. And if you look at the pulmonary artery, the lower end of it, where the valves are, you can see that it's become enlarged. We have pulmonic stenosis, and remember, anything that's stenotic means that it's stiff. It's not opening and closing the way it should, so it's hard for blood to get to the lungs. The pathophysiology involved in tetralogy of Fallot will be dependent on the hemodynamics, or meaning that the hemodynamics can vary. Which way the blood is shunting depends on where I have least resistance, whether it's systemic or pulmonary, and the cyanosis of my child may be very severe. At birth, my child may be cyanotic. When I listen to the child's heart, I may hear a very loud, harsh murmur. What's specific to this defect is something called TET spells. When the O2 demand has increased, the child will instinctively know how to compensate, and what they do is that they will squat. And they'll be running and they'll playing, and now their O2 demand is increased to a point that they can't handle it, and they'll just squat. And you'll see them rest for a little bit and then get back up and do what they need to do. So that squatting action helps to shunt more blood to the upper torso. So that gives the heart a little bit of extra volume to pump and to do what it needs to do. It also keeps the blood, or the heart rather, from having to perfuse the lower extremities. So it's a compensatory mechanism. This is something you can use as a pediatric nurse. If you have a child coming in and they're coming in for any reason, they're a tetralogy child, that's their diagnosis, and they're coming in even if it's not related to the cardiac defect, and you need to do some intervention that's going to increase their O2 demand, you can have them bring their knees to their chest, or you can position them in such a way that it mimics that squatting position. These children, because of the increase in their RBCs and the hematocrit, they're more at risk for emboli. They're at risk for seizure activity, also loss of consciousness, or sudden death. The surgery to completely repair a tetralogy of Fallot is involved. This is a child, up until this point, if a child came back from surgery, they probably have one chest tube to drain any secretions or fluids from the surgical site. This child will come back with at least 2 chest tubes. They're going to be intubated overnight. They're going to be paralyzed. It's a pretty involved surgery. So we have the child get as old as they can before the surgical procedure is done. They're put on a heart-lung bypass, so it is much more involved. Initially, the child will be treated palliatively with shunts. Dr. Blaylock, Dr. Tossing, that's how those names are there, are the ones that design these shunts. And the shunts actually create blood flow back to the pulmonary artery to increase blood flow to the lung. I'm not fixing any other defects in the tetralogy process, but I'm just trying to get some extra, get enough blood flow to the lungs. To do a complete surgical repair, the VSD needs to be closed. The area that's stenotic on the pulmonary artery needs to be resected. When the VSD is repaired, the aorta is positioned in such a way so that it's out of the left ventricle and it's not midline. Because I've now decreased the blood flow to the right ventricle, eventually that muscle will begin to atrophy and return to a more normal size. It may not completely be a normal baseline right ventricular musculature, but it will be a lot less hypertrophy. Tricuspid atresia is another example of decreased pulmonary blood flow congenital heart defect. Atresia means that there's no opening, there's anything that's atretic, there's not a connection, the normal connection that should be there. So the valve between the right atrium and left ventricle fails to develop, and there's no communication. So here's a good example of us needing to have some other defect present in the heart in order for the child to survive. There's going to be an ASD, or there's going to be a PFO, patent foraminovalle, that needs to stay open. If it's not open, then oftentimes, or if it's not there, then oftentimes surgically they will go in and create it until the tricuspid atresia is able to be fully repaired. Here's a slide representing the tricuspid atresia, you can see there is no connection, there's no communication, there's no valve between the right atrium and the right ventricle. So blood cannot get to the lungs. There has to be some other communication, whether that's an ASD, a patent foraminal valley, a PDA, something has to be there so we can get blood to the lungs. With tricuspid atresia, there's a mixing of unoxygenated blood with oxygenated blood. So I have the quality of blood being pumped out to the rest of the body is going to contain some desaturated blood. When I assess this child, I'm going to usually see cyanosis at birth. I'm going to hear a murmur, increased respiratory effort. They're going to be weak. They're going to have a gray color to them or a pallor color to them. They're going to be cool. They're going to have an increased heart rate, a hard time breathing, and chronic hypoxia. And because of the chronic hypoxia, you all know from your health assessment class that in my older child, I'm going to see clubbing. Palliatively, we're going to use shunts to increase blood flow to the lungs, and then to modify the treated area would be the permanent corrective procedure. Our third classification of congenital heart defects is obstructive disorders. Within the obstructive disorders, there's some narrowing of some major blood vessel that is either keeping blood from going to systemic circulation or to the pulmonary circulation. Regardless of where the obstruction is, it's causing an increased workload of the heart. One defect that falls underneath this classification is coarctation of the aorta. There's some narrowing. It's usually around where the PDA would occur. That's some narrowing that's impeding blood flow. The pressure proximal to the coarctated area is increased. Pressure distal to it is decreased. Think of a garden hose when it's kinked. The pressure leading up to it is increased in the garden hose, and you just have a trickling on the other end. So depending where the coarctated area is, where the narrowed area is, will then indicate the lack of perfusion to that area. You can see in this slide the narrowed aorta is where the PDA would have been. So I will have decreased blood flow to the body, to my lower extremities. I may have, because I have increased blood flow to the upper extremities, I may have a headache. I may, when I feel pulses, my pulses on my upper extremities are going to be bounding. My lower extremities may be hard to feel. If I feel them, they're going to be weak because of the lack of blood flow to those areas. With this defect, blood flow will be impeded, blood pressure will be increased in the area proximal to where the coarctation exists. So for example, blood pressure in upper and lower extremities should not vary that much. In a child with a coarctation of the aorta, you may see the upper extremities blood pressure be higher than lower extremities. This is why in newborn nursery, and we're obtaining those first sets of vital signs, we do a blood pressure in the upper extremities and one in the lower, and a comparison is made. If there's a significant difference, then we're concerned about coarctation. Your clinical assessment findings for this defect in your patient would be elevated blood pressure, bounding pulses in the upper extremities, weaker femoral and lower pulses. The lower extremities may be cool to touch. My child may present an acidosis because I am not perfusing tissue. I may have vertigo, I may have a headache, and I'm at risk for hypertension and aortic rupture. Treatment procedures that you'll see done for a child may be a balloon angioplasty, very similar to the process of when I have an adult patient and I need to open up the aorta because plaque has formed there. They will go in and they will inflate the balloon. It may not be the normal diameter to someone who didn't have a coarctated aorta, but enough to where the child has no issues from it. If the coarctated area is too involved or too large, you may have you may see them go in and take out the narrowed area and place a graft. Aortic stenosis is another defect that falls underneath obstructive disorders. There's an obstruction of blood flow between the left ventricle and the aorta. Anything that's stenotic, we've discussed already, the valves are stiff, they don't open and close the way they should, so it's hard for blood to get through into that vessel. Aortic stenosis may be progressive, meaning at first the child is not that symptomatic, and as the child gets older, it becomes more of an issue. The concern is the low cardiac output. Remember, we've talked about that there are certain numbers, there's a volume that I want. For right now, you just need to understand that if I don't have that correct cardiac output, then that can lead to sudden death, especially if I have increased my output needs, if I've increased my O2 needs. This is something sometimes you'll see in the news where the star athlete, drops dead during a basketball game, and as the event is being investigated, this is a child that maybe had a temperature, was a little bit dehydrated, or was in some kind of tournament, lost a lot of fluid, has aortic stenosis, didn't realize, but now my O2 demand is so involved that I have that sudden death. You can see in this picture the significant left ventricular wall thickening or hypertrophy. As the blood is not able to filter into the aorta, then the musculature becomes larger and larger, trying to pump harder. And you can see now where my left ventricle becomes so small that I am not able to hold enough blood volume in that chamber. So that's another contributory factor to the sudden death. This slide just highlights everything we've already had a discussion about in regards to aortic stenosis. The child may present with the decreased cardiac output signs and symptoms we've talked about. They may not be able to tolerate exercise. You're going to hear a harsh murmur. And this child, we've talked about this before in regards to the VSD, is at risk for bacterial endocarditis. That would be an acquired congenital heart disease secondary to the defect. That turbulent blood flow, that blood being pumped up against the aortic valves, causes the blood to create little clots. Those clots clump together, and now there's a protein source for bacteria to grow. As far as treatment for aortic stenosis, you'll see the child possibly undergo a balloon dilatation or replacement of the valves. Pulmonic stenosis, the etiology or the pathophysiology, what occurs is very similar to aortic stenosis. We talked about pulmonic stenosis when we talked about tetralogy of Fallot. This is another defect that's under obstructive disorders, and it obstructs the blood from going to the pulmonary artery. You can see in this slide, because of the stenotic area of the valves, that the right ventricular area has hypertrophied or thickened, trying to compensate for the blood volume that's not able to be perfused to the lungs. With pulmonic stenosis, I have resistance of blood flow to the pulmonary artery. I'm not able to get enough blood flow to the lungs. The pressures in the right ventricle will increase, thus the pressures and the blood volume will increase in the right atrium, and that may cause the foraminal valley to reopen. With pulmonic stenosis, I may initially be asymptomatic, or I may have some mild cyanosis or congestive heart failure. It just depends on how stenotic the area is. I may have an enlargement of the heart, and again, this child's at risk for bacterial endocarditis. Treatments you may see ordered or done for this child with pulmonic stenosis, again, a balloon angioplasty or replacement of the stenotic valves. This last classification group of congenital heart defects is the mixed defects. This is not something that I'm going to hold you all responsible for, but I did want to just review it with you. These are the defects that students often find interesting because they are so involved. I don't see these defects as often as I used to with our sophisticated sonograms and information parents are given at a much earlier stage of their pregnancy. Most of these children are not carried to term. So with a mixed defect, it is a very complex defect that has a mixing of both the pulmonary and the systemic blood flow. Depending on the pressures in the heart, depends on the hemodynamics, which way that blood is going to be flowing, whether mostly to the lungs or mostly to the systemic circulation. The first congenital heart defect under the mixed defects category or classification system is transposition of the great vessels or arteries. When I show you a slide in just a minute, what happens in this defect is that the pulmonary artery is coming out of the left ventricle and the aorta is coming out of the right ventricle. So all the structures are present. There's no communication, there's no abnormal openings, everything's opening and closing like it should. We just have the major vessels coming out of the wrong side of the heart. As involved as that is, that is the only thing that is wrong, and the vessels are switched during a surgical procedure, and truly the child has no other issues. You can see in this picture the pulmonary artery coming out of the left ventricle and the aorta coming out of the right ventricle. Thus, the blood being pumped out to the body is only deoxygenated blood, and the blood going back to the lungs is oxygenated blood. For this defect, as a couple of others that we've talked about, there has to be some way for the two circulatory systems to have a connection. So a septal defect or a PDA must be present so that we can get blood into the pulmonary circulation. If it's not present, then one will be created. One way for healthcare to ensure that the PDA stays open is to administer prostaglandin. We talked about indomethacin earlier on when we talked about a PDA, and we discussed that we give indomethacin because the classification is a prostaglandin inhibitor. So to keep it open, we would do just the opposite. The classification of drug that we would give is a prostaglandin. We do that so that there is a communication between the two circulatory systems. If that isn't working, there's not enough blood flow, then you may see the child have a cardiac cath with the balloon to create the ASD or to make the ASD bigger. Eventually, the vessels are switched, and whatever defect that was accommodating the life of the child, the ASD or the PDA, that's also corrected. Another interesting defect that you'll see in the mixed defect classification is something called truncus arteriosus. Instead of having a distinct pulmonary artery and a distinct aorta, they are all connected in one huge vessel, and they're intertwined within that vessel. Depending on where the blood, depending on the pressures between the pulmonary and systemic circulation, will determine where the blood flows. This slide shows you where the aorta and the pulmonary artery are all connected within one big trunk structure. Again, the blood flow is determinant on the pressures in the pulmonary and systemic circulation. So the pressures with least pressure would be where the blood would flow, either to the lungs or to the body with truncus. For truncus arteriosus and some of the other mixed defects, the corrective procedure would actually be a heart transplant. And here is a slide of a picture of a heart being ready to be transplanted into a pediatric patient. We have covered so far in this discussion the different classifications of congenital heart defects. We've talked about increased pulmonary blood flow heart defects, decreased pulmonary blood flow heart defects, obstructive heart defects, and the mixed defects. Again, the mixed defects were more just to show you some examples of the more involved defects you may come across in your practice, but not to hold you responsible for that. Irregardless of the classification, your nursing considerations are to improve oxygenation of the child, to make sure the child has adequate nutrition, to provide coping mechanisms. That's both for the child and for the parent. As you can see that even with the less involved defects, there's parent teaching and growth and development parameters that we need to consider. We need to prevent infection, and we need to make sure that we're providing adequate education for both the parent and the child. We've discussed the different classifications of congenital heart defects in regards to my pediatric patient. Now we're going to review cardiovascular disorders that the child is not born with, but that they acquire it. Sometimes these acquired disorders are secondary or because of or a sequelae to the congenital heart defects, and sometimes they're not. Congestive heart failure is the first acquired cardiovascular disorder that we're going to talk about. We did discuss it somewhat when we did increased and decreased pulmonary blood flow, but we're going to break it down to some more depth right now. A good definition is seen here on the slide. It's an inability of the heart to pump adequately at normal filling pressures. Some causes of congestive heart failure in your pediatric patient, actually in any age patient, would be if there's a volume overload, and we talked about how that can occur in our left to right shunts. If there's a pressure overload, if for some reason there's decontractility or less contractility, a decreased in contractility of the heart muscle, like in a cardiomyopathy, or if I have such high cardiac output demands that my heart cannot adequately pump out or perfuse as needed. When you're thinking about congestive heart failure, if you think about it in regards to discussions you've had with your adult patients, you might be thinking, is the congestive heart failure right-sided or left-sided? Meaning I either have suboptimal functioning of my right ventricle or left ventricle. For my pediatric patients, we're not going to do that, although the congestive heart failure may start on the right side or may start on the left side. Because I have a smaller body surface area, I don't really stay on either right-sided or left-sided heart failure. I will present with both. So for our discussion today, we're going to talk about it in terms of pulmonary congestion or systemic congestion. So when I assess my child, what am I going to see clinically? I have impaired myocardial functioning. My heart is not pumping the way it should. So again, I'm either going to see pulmonary vascular congestion or systemic congestion. With impaired myocardial function, here are some signs and symptoms that are listed for you. Because my heart is not pumping effectively, I'm going to increase that heart rate. When I listen, I'm going to have a gallop rhythm or that third heart sound. My child's going to get tired more easily. They're not going to tolerate exercise. They're going to be irritable. They're going to have poor weight gain. They're going to have a slow capillary refill, a low blood pressure, and my color may be pallor or dusky. For my pulmonary congestion, we talked about this in regards to increased pulmonary blood flow defects. I'm going to have an increased heart rate. I'm going to have hypoxia. I may have mild cyanosis. I'm going to have impaired gas exchange. I'm going to be working harder to breathe. When I listen, I may hear wheezing. I may hear rails. When I look at my child, especially my young infant, they may be grunting, and I'm going to have a failure to thrive. With this increased workload, I'm going to have an increase in basal metabolic rate, so my child has an increase in caloric needs. With my systemic congestion, I may have hepatomegaly, splenomegaly. I'm going to have sodium and fluid retention. I'm going to have weight gain. And I may, in my older child where I can actually see the neck veins, I may have distended neck veins. When you think about edema in this child, with your adult patients, we tend to look at the lower extremities. For systemic venous congestion, I'm going to see the edema, first periorbital edema, Then in my young infant, anything that's supine. So in my infant that's being laid on their back to sleep, I'm going to have sacral edema, and in my male patients, I'm going to have testicular edema. I can have lower extremity edema in my older children, but it is not as common as I see in my adult population. So what do I want to do for my child in congestive heart failure or heart failure? I want to improve their cardiac function. This means that I'm increasing the heart's ability to contract, and after that heart does contract, I have a decrease in the afterload volume. Afterload and preload are terms that you're going to explore more in other courses, but it's the amount of fluid, the amount of blood volume left in the heart for the afterload after I contract. There's certain numbers and there's certain pressures that go with that. I also want to decrease the O2 demands. I want to remove excessive fluid that the child has retained and sodium. And I want to improve oxygenation of the child. So what are some ways I might see the child being cared for in regards to improving the cardiac function? Digitalis or digoxin is a medication that will be ordered for your pediatric patient. Remember from pharm that improves the contractility of the heart. And an ACE inhibitor may also be ordered to help deal with the afterload of the heart, blood volume in the heart. Remember the dig or lanoxin. I have lanoxin up there because that's the PO form, the PO name for digoxin, the liquid one. For digoxin, it increases the force of the contraction. It's a positive inotropic and a negative chronotropic. So it allows my heart to contract better, and because I'm contracting more effectively, I don't need to contract as often. So it works on the SA node, and I'm going to have a decrease in my heart rate. In your book, there are parameters for what we would expect to see for my infant, my toddler, and so on. I am going to suggest to you that you always have a provider write an order so that everybody delivering that medication is going by the same number value based upon the child's baseline. But some things you do need to know is that heart rate, that apical heart rate, needs to be taken for 1 full minute. You're not taking anything off the machine. You're not doing it for 15 seconds and multiplying by 4. You listen for 1 full minute, and then you follow the parameters. Because it does help my heart increase my cardiac output, that perfusion to my body will also perfuse my kidneys. Anytime I have a decrease in cardiac output, your body, because it's wonderful, thinks, oh, I don't care if I perfuse certain organs, I want to make sure I perfuse the heart and lungs and the brain. One of the organs that will have a decrease in perfusion is the kidneys, which is why I'm holding on to that sodium and that fluid. But with a good contraction and increase in my cardiac output, I'm going to be perfusing my kidneys better, which is going to cause me to urinate and get rid of some excess fluid. So indirectly, it also helps with diuresis. We do need to remember as pediatric nurses, the dig or lanoxin has a rapid onset, whether it's PO or it's IV. So we need to be very aware of what the side effects are of toxicity. You remember from pharm that your patient may have an upset stomach, or may see an aura or a headache. Your young child is not going to be able to verbalize that to you. So some of the things we need to remember about dig toxicity, or that I'm getting those higher levels of dig, is that I'm more lethargic, I'm more sleepy, with my nausea I may vomit. So it's very important that we pay attention to that. ACE inhibitors also help with my myocardial function. Remember, it blocks the conversion of angiotensin 1 to 2. This should be a review for you from pharmacology. It also helps reduce the secretion of aldosterone. And remember, aldosterone helps us from holding on to the sodium, and so thus we're able to get rid of fluid. Improving tissue oxygenation for this child is another therapeutic management nursing goal that I have. Supplemental oxygen, if indicated by the child, that may be delivered in the form of a nasal cannula, a face mask, an oxygen tent. We don't use a lot with children anymore. It doesn't mean that you won't see it, or an oxy hood in my young child that keeps the oxygen within in a close proximity to the child. Oxygen is a drug and it does need an appropriate order, but if the child is needing it right there, we can place the oxygen and then get the order later. My nursing interventions also need to include decreasing the cardiac demands of this child. If I can decrease what the child needs, then hopefully what the cardiac output would better suffice for what their body is requiring. So for my young child, I want to make sure that the environment is neutral. If it's too cold, especially for my newborn baby, that's going to increase their needs. Any infection increases cardiac needs. I also want to position the child in a semi-Fowler's position. They can breathe easier. And I want to think about how I'm providing my nursing care. I want to make sure the child is able to get the rest that they need and that I'm decreasing environmental stimuli. To remove excess fluid and sodium, you're going to see diuretics ordered for your child. Lasix is one. We need to make sure that when we're administering Lasix that we're also monitoring the electrolyte potassium, especially if my child is on digoxin. A low potassium level, blood potassium level, serum potassium level enhances the effects of digoxin, so it'll take less of dig to get the effects that I'm wanting from the medication. Thus, toxicity can occur quicker and in a shorter time period. So I really need to pay attention to that electrolyte. The child may be on fluid restriction, the child might be on salt restriction. It just depends on how well I'm able to manage the fluid balance of the child. Hyperlipidemia is not a result of a congenital heart defect, but is acquired. The child is not born with high levels of lipids. If you remember from our physical exam discussion, we screen routinely for health promotion and wellness starting at age 3 for cholesterol levels. There might need to be some management or discussion on lifestyle and food intake with the parent. The numbers that you want are the same as with your adult patients. The new parameters or the new suggestion is that everybody has a total cholesterol level of 170 or below, irregardless of age. Bacterial endocarditis, again, is an acquired cardiac dysfunction, and we discussed that anybody can have bacterial endocarditis, but our children that have that turbulent blood flow, or the blood that is trying to get through a stenotic area where the blood is hitting up against those valves, or more at risk. The vegetation tends to grow around the valves and the inner lining of the heart, and it can damage or destroy the heart valves. The most common agents are our strep and our staph. So my child that has a congenital heart defect, has the turbulent blood flow, I am really on top of. I really want to monitor and ensure that when my child gets a strep throat infection, that all the things we've talked about previously in managing that strep throat is followed explicitly so that I don't have the issue of the bacterial endocarditis. This slide just reviews the vegetation on the valves and the increased risk for the children with a congenital heart defect to acquire this disorder. Clinically, what you're going to see with a child with bacterial endocarditis is that the symptoms are insidious, meaning that generally they just don't feel good, or they might run a low-grade temperature. The key to picking up on this or having this trigger in your brain is that you need to know the child's baseline heart sound. So for example, if they have an S1, S2, S3, and now you're hearing an S4, that needs to be a consideration that now the child has bacterial endocarditis, or if the child had a grade 2 murmur and now it's a grade 3 murmur, that anything that changes about this child's baseline, the investigation of bacterial endocarditis needs to occur. Some other things that you may see is splinter hemorrhages, and it looks like, if you look at the child's nail beds, it almost looks like they've gotten a little splinter underneath there. But what it is the platelets or the little clots that have broken off and have traveled down, and you're seeing them in the nail beds. The medication used to treat bacterial endocarditis is high doses of penicillin. Prevention is really the key. The children that we know that are at risk for this, the children that have that turbulent blood flow, the children that have the certain defects that we've talked about, we will have them take an antibiotic, a penicillin-based antibiotic, 1 hour before the invasive procedure. To include dental work, if they're having teeth cleaned, if they're having teeth pulled, we don't want to set them up for the chance of acquiring the bacterial endocarditis. So some primary prevention things for this is making sure that my child has good dental care, making sure that they're not needing any of the invasive procedures that might require the antibiotic. Rheumatic fever is another acquired cardiovascular disease that can occur, and it's not connected to a congenital heart defect. It's an inflammatory disease that occurs after a group strep pharyngitis. Rheumatic fever itself is self-limiting, meaning that it will go away by itself. The reason that we treat it, the reason that we're concerned about it, is that it can lead to rheumatic heart disease, and that's the most significant complication. So it's a strep pharyngitis. It's an inflammatory disease that happens after a strep pharyngitis was not treated or impartially treated. Inflammatory hemorrhagic lesions are formed, and that's the pathophysiology for the rheumatic fever. These lesions can be formed on the surfaces and the vessels of the heart. Therapeutic management for this child is getting rid of the group A strep infection, so penicillin is a drug of choice. We want to prevent any further cardiac damage, so the child will be on bed rest to decrease the demands of the heart. We're going to treat all the other symptoms palliatively, and we want to prevent any reoccurrences. These children might be put on a low-dose antibiotic for a couple of years afterwards to make sure that they don't present again with this disease. So penicillin is used as long as the child's not allergic to it for the infection, and we talked about possible prophylactic treatment. Aspirin therapy may be used for the inflammatory response, and we've talked about in the past that we don't give children aspirin because we don't want to have another complication called Reye syndrome. But we know that this is not viral. We know it's a bacterial issue, so it's safe to do that. And also, the child may be put on a prednisone or a steroid medication if necessary. Kawasaki's disease is another acquired cardiovascular disorder. It's a vasculitis of the cardiovascular system, and we're not really sure what causes it, although we tend to think that it's viral because it's more pronounced in the fall till springtime. It is self-limiting, meaning that it will go away by itself, but the reason we're concerned is that if we don't treat it, there's cardiac sequelae in about 1/4 of the children. So the pathophysiology involved with Kawasaki is that we have inflammation of the small and medium vessels. If we draw blood work, your ESR is going to be elevated, the C-reactive protein is going to be elevated, and we're concerned about myocardial ischemia or infarction because of the inflammatory process. Here is a listing of some clinical manifestations you can see with your child. Kawasaki has 10, 13 criteria, and if you look at a diagnostic manual, the child needs to present with like 8 of them in order to get the diagnosis of Kawasaki's. And it's usually a diagnosis that the parents hear about after everything else is ruled out. And so let's look at this list and see if that makes sense to you on why that occurs. It's acute. Initially, the child will have a high fever, and the parent will bring the child into the primary care setting, and maybe sometimes based upon blood work or based upon clinical presentation, the child might be put on an antibiotic. Definitely the parents are instructed on how to give antipyretics, but the fever doesn't go away. The antipyretic really doesn't do a whole lot for them. The child may present with conjunctiva that's red, but there's no discharge, so it's not a conjunctivitis or a pink eye. The pharynx will be red and inflamed. The tongue, we call it a strawberry tongue because it's swollen. And if you look at it, it looks like a strawberry. They may have an erythemic rash that's more pronounced in the perineal area. The palms and the soles of the feet may become very edematous and very erythemic. And they are very, 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 did I use the word very, irritable. This is a good pictorial description of what a child with Kawasaki looks like. They are just miserable. It is hard to console them. So by the time the child ends up in the inpatient setting, it's been a couple days, sometimes a week worth of, we think it's this, we think it's that, and then eventually the diagnosis of Kawasaki is given. Here's a picture of that strawberry tongue that's connected to Kawasaki. Between the strawberry tongue and the red pharynx, one nursing diagnosis that applies to this child is risk for fluid volume deficit. And the subacute phase of recovery for Kawasaki's disease, the fever will go away. The child may present with hypercoagulability because of the inflammatory response that was part of the disease process. There may be some discrimination of the hands and feet, and the child may complain of some joint achiness or arthritis. The convalescent phase, all the clinical signs and symptoms are gone, but if you draw lab work on this child, you're still going to have elevated ESRs and C-reactive protein. This can take a couple of months to fully recover and to have no clinical or subclinical presentation. Medications or the management that you'll see for Kawasaki, because it is an immune response, we're going to give high doses of IV immunoglobulin. Also the aspirin, the salicylate therapy, there's some dosing ranges there for you, not to memorize, just to give you a reference base, and then anticoagulatory therapy may be indicated for the child. Systemic hypertension, again, is an acquired cardiovascular dysfunction that is not because of a congenital heart defect. It's the most common cause of a CVA or a stroke. Your book breaks it down into primary and essential hypertension. Those really are both the same. So let's start with secondary. Secondary hypertension is secondary or because of another disease process. So my children who have renal dysfunction may have hypertension, but it's secondary to a disease, to another disorder. Primary or essential hypertension is what you're going to see in regards to inactivity, poor intake, high cholesterol levels. It's the primary reason, the primary connection to those lifestyle choices. Just as with your adult patients, the clinical presentations or assessment things that are connected to hypertension are headaches, vertigo, changes in visions, and behavioral changes. So let's think about that in regards to my pediatric patient. A little one may not be able to even tell you that their head hurts. They don't have the verbal skills or understand that that's what's going on. Changes in vision, blurred vision. Again, the child may not be able to verbalize to you. They just accept what's going on. And the behavioral changes, the parent may not realize it's because of the hypertension. So just as with my adult patients, these are the same clinical assessment findings that are there. It's just in my pediatric targeted population, it may be harder to get that information. Nursing management, therapeutic management for this child is dietary practices and lifestyle changes. They need to decrease the processed foods, the fatty foods, the calories perhaps, and they need to get some aerobic exercise. We may need to evaluate the use of their salt. These children oftentimes, if they're very symptomatic or if we're not having good results or good outcomes with the lifestyle and dietary changes, they can be put on ACE inhibitors or beta blockers for the same reason that your adults are on them. So we really want to go back to those initial discussions we've had about prevention and wellness and having the child reach their optimal level of health through dietary and lifestyle changes. And of course, this is really what we want to see in our pediatric population, a nice, healthy child. Let's look at some review questions now.